Some babies with carbohydrate intolerance, which can be transient, as we discussed with diarrhea, or it can be due to other reasons like galactosemia. So they cannot metabolize galactose. The lactose and galactose-free diet should be recommended. We normally use a soy-based formula like isomil. The sugar is fully lactose-free in these cases. Mostly it's cornstarch-based. The normal lactose-free milks are not licensed for use in galactosemia, mainly because the source of the protein is also from the cow's milk, and during the separation process, a degree of lactose is retained in the proteins. So please remember that lactose-free milks are not ideal. Lactose intolerance is another condition where there's inability of the small intestine to produce enzyme lactase. Majority of the time, it's a secondary lactose intolerance, but it can be primary, and it may be a mild form where reducing the content may be enough. The soy-based formula, low lactose or lactose-free formula can be used. Some babies present with frothing, explosive loose stools with severe nappy rash. Remember that zinc supplementation may be needed in some of these babies to help with the nappy rash in addition to the low lactose formula. There are also special formulas for certain conditions like maple syrup urine disease, where we should use a formula free of leucine, isoleucine, and valine. In phenylketonuria, you use phenylalanine-free formula. In conditions with lymphatic dysfunction, like a chylous fistula or chylothorax, milk high in medium chain triglycerides are needed, like monogen. There are special formulae like Calcilo XD, which can be used in hypercalcemic conditions like Williams syndrome or primary hyperparathyroidism. In chronic renal failure, we may have low renal solute load, low potassium, calcium, phosphate, and chloride. And examples of these are Kindregen and Renastat. Other conditions like poor weight gain and high energy milk high energy milk can be used in these situations. Where we have short gut syndrome, extensively hydrolyzed formula may help because there is less stress on the gut for absorption. In preterm babies in the hospital, we use preterm formula. The difference between the preterm formula and the term formula is the calorie content. So the preterm formula has about 80 kilocalories per 100 ml. The protein content is higher as well. There is 2 gram protein every 100 ml. There's more calcium, phosphorus, sodium, and other supplements as well. So it's meant to meet the requirements for the preterm babies when they are reaching about 150 to 160 ml per kilo per day. The post-discharge milk is a special formula which is meant for preterm babies to be used at discharge. They have composition in between that of the preterm formula and the term formula. The calorie content is about 74 kilocalories per 100 ml. The protein content is 1.6 to 1.7 grams per 100 ml. And they also have a higher level of calcium, phosphorus, and iron vitamin supplements. These can be used after discharge in the preterm babies till 3 to 6 months, depending on the weight gain. I usually stop it when we reach a weight of 4 to 6 kilograms.